Okay.
Good afternoon. I'm Phyllis Salyards, co-president of Hastings Legal Win Voters, and we are happy to welcome Michele Bever, our director of the South Heartland Department of Health, who has been doing yeoman service for several years, but especially since the onset of COVID. And we asked her to come back to give us a progress report on where we stand now, and also to bring us up to date on where we hope to go and how we're going to get there, and if there's anything we as league members can do to help. Michele.
Thank you very much for having me. I really appreciate this opportunity. And I've got some prepared things to say that will, I think, take us back through the beginning of this pandemic and bring us up to where we are, and maybe remind everybody of what this year has been like. And then I want to share some current data and have hopefully plenty of time for folks to ask questions. I will want to share my screen at some point. I don't need it right away, but is that possible to do that? Okay.
Yes.
I actually, maybe I'll have this up so then you have something to look at besides me. And
then you can, whenever you want to, or maybe it's already working. Hey, looky there, it already worked.
All right, you can see it?
Yeah.
Yeah, okay, and I'll get to that eventually, but I wanted to start by thanking all of you for all of the ways that you have contributed to this process, this community response to the pandemic. It's been a very long about 16 months for us to date. And if you'll recall, this virus outbreak began in Wuhan province in China. And on January, and that was December that it was first identified. On January 21st, 2020, the first confirmed case of coronavirus was detected in the state of Washington in the United States. And Japan, South Korea, Thailand, they reported their first cases about the same time. On February 11th, 2020, so we're still over a year ago, the World Health Organization gave the virus its formal name of COVID-19, and calling the virus or the disease, and the virus itself was SARS-CoV-2. On February 29th, the first death was reported in the United States from COVID-19, and the World Health Organization declared a pandemic on March 11th. So since March 11th, over a year ago, we've been battling this pandemic worldwide. We actually began preparing for the COVID-19 outbreak probably mid-January, and in 2020, and we stood up our Public Health Coordination Center, which is kind of like an emergency operations center for emergency management, but that's what we have around public health. And we did that on January 29. We had surveillance staff that were monitoring the activity in China, watching the number of cases double each week, aware and preparing as cases spread to the United States. And the health department, we worked closely actually with Hastings College early on because of all the plans for travel for spring break and travel courses and things like that. So we were working really closely with the college as they prepared for groups of students to travel abroad, and looking at what they would do as they came home, if there were exposures, what would that immediate quarantine look like, what processes would be in place. And we ended up reporting on March 18th. Our first local case of COVID-19 actually was a member of a travel team, but there was no additional spread because we had all these things in place. Everything was very well implemented. And so that was great. During March, our surveillance staff, and that including me at that point, we took calls at all hours from hospital emergency departments and healthcare providers to answer questions and facilitate testing for patients who had symptoms that might be consistent with COVID-19. There was a lot of uncomfortable calls, worried calls, anxious calls. Could this be a case? Could this be a case? It's flu season. You know, we have the same sort of symptoms appearing, and so we had very limited testing at the time. So it all had to be approved through us. And then as more cases appeared locally, we responded by utilizing a full epidemiology team that we put together that completes the investigations and the contact tracing, referring people to testing, notifying them if they needed to be quarantined or isolated, notices of release of quarantine or isolation, and monitoring those that were on quarantine or isolation. Very heavily involved processes at that point. We had a team that provided the investigation, the instructions, the communications that was language appropriate, health literate. So a lot of work in that arena as well. And in July, we began working with the state's contact tracing team as well. So they had stood up and trained a number of folks so that when we became overwhelmed with the number of cases, we would have a place to access resources to help us. And we did use those in the fall quite a bit. So our team monitored best practices and guidance from CDC, Nebraska Department of Health and Human Services, some of our professional organizations, the World Health Organization, and we connected resources to local healthcare providers and other entities to make sure our whole team and our partners and our stakeholders were applying the most up-to-date practices and materials, which were changing very, very frequently. So it was a lot of work and still is a lot of work to stay up on all of the new things. We were trained in new databases that we needed to use and training more staff to use them to help gather and process and report information. And we worked closely with long-term care and businesses, work sites, healthcare facilities and practices, and had some specialized responses to outbreaks in those types of settings, including arranging for strike team testing sometimes and encouraging implementation of prevention measures to reduce spread. There was also special teams at UNMC to help with food processing plants and also with long-term care facilities with experts that would help guide them in the processes of prevention and following up on outbreaks and the things that they needed to do with next steps to protect folks and prevent further spread. So lots of great resources at the statewide. I mentioned testing, and the availability of testing changed a lot over the course of the first 6 months too. At the beginning, it was really, really restricted. Only those with severe symptoms needed to be approved by local public health, and they could only be processed through the Nebraska Public Health Lab. So healthcare providers didn't have access to that. No rapid tests and nothing like that. So as we had more testing supplies become available and more commercial labs were able to process those samples, some of those restrictions on who could be tested were lifted. So we could do more folks, and that was helpful in understanding what was going on in the community. Because if there's not testing, we don't know whether there are positives. We don't know who needs to be quarantined or who needs to be isolated. And so there's a nice balance that needs to occur with the amount of testing and our ability to manage an outbreak. We worked with DHHS then to arrange for Nebraska National Guard testing. So you might recall that the National Guard was stood up to help with some of these mass testing events, and they would move around the state. And then Test Nebraska became available as well, and they started using that. And we had them come to do some mass testing events in our district, especially in Clay and Adams County, and had some strike teams that went out and did some testing at long-term care or at meat processing facilities. And then beginning in May, we started working with the state, trying to convince them to have local contracts for Test Nebraska so that some of our hospitals could do that. So it would be here all the time and not just occasional mass testing events. And Mary Lanning picked up one of those. Broadstone in Superior, Webster County, and Hastings Convenient Care have been the ones that have been using that Test Nebraska, making it available. It's free, it's available for folks, and that's been really great. We started tracking a bunch of new indicators. So what's going on in our district? Well, what's the daily and cumulative cases overall and by county? What are the symptoms that we're seeing? What's the age and race and ethnicity that's being affected? What are their occupations? How many hospitalizations? What are the deaths? How many are tested? What's the positive test rate? All these things we started collecting the information for and analyzing, needing staff to help us do those. and then sharing those trends and summaries first on our website, and then eventually getting the capabilities and the right excellent public health students to help us put up our dashboard and able to track more things that way. And we have continued to expand on that as we have more indicators in different phases of the pandemic. And so we have been trying really hard to do a lot of communication of information. And I'm going to come back to that in just a little bit. But another key thing early on was resources. So personal protective equipment very early on was something that was really needed in the clinics and the hospitals, the long-term care places, any places where there might be exposures. And we started out with a cache that we had anyway in our district. And once that was used up, the state cache was brought in. And once that was used up, there were federal supplies that were brought into the state and brought locally. And so we were really working on that. N95 masks were especially in short supply, and there were other things as well that we had to wait on sometimes and use other resources to help make do. But we were distributing things like thermometers and face shields and gowns and masks to hospitals and medical clinics and EMS and emergency managers and schools and critical infrastructure, long-term care facilities. So lots of movement of supplies, and it became quite a large operation for us to do that. We have processed, I was going to get my most recent notes, from March last year through the end of April this year, we had distributed 193,455 surgical masks, 264,800 cloth masks, 51,000 face shields, 14,201, sorry, I'm off on this. One of those was, I'm off, so face shields was 14,201, goggles was 2,945, hand sanitizer, 1,315 containers, sanitizing wipes, 9,240 containers, and then 624,000 gloves, 179,000 gowns, thermometers, bleach, disinfectant containers. So lots of stuff moving through, and we had fairgrounds space where we stored these things, and we had people that would come and get the supplies and take them back to their counties and distribute them out to the folks that needed them there. So it was quite a large operation for that. And then we were getting into the summer, and we had directed health measures, and that had started in March, and things started lifting out, and I'm going to talk about that in a little bit too. But we had to review a lot of plans as people were shifting from one set of restrictions to another, and that was required by the state that the health departments review plans. And so we were reviewing and approving those and needing a process in place to do that. Sports events, livestock and county fair sorts of things, weddings, July 4th celebrations, graduations, all those types of things, large gatherings of any type, indoors or outdoors. At that time, we had to review and approve those things. So that was another piece that we were doing. We had to take staff redirecting from their usual duties and sending them off to get trained, not sending them off, but getting them trained up and ready to implement personal protective equipment, supplies management and distribution, or active monitoring of cases, or doing contact investigations, or figuring out how to do public education and materials development, things that weren't their usual things to do, website capabilities, handling all the huge call volume that we had. So we had to add capacity by recruiting volunteers and hiring or contracting with people. We had our own worksite prevention practices in place at the office, and we beefed up our technological capabilities and our policies for working remotely and being safe when we were here. So that was a little bit different for us, like it was for many work sites. And to help keep our partners informed, we have been using a ton of different venues. So we've been using our web-based alert sense notifications for some partners with little texts that come through with updates, local health alerts that are often faxed to different places. We have social media and our web-based data dashboard, news releases, public health columns, in-person and virtual press conferences, and billboards and community signboards and advertisements and radio and TV interviews, and message on hold on our phone system when people are waiting, they get information that way. encrypted emails. We have a web form that people can submit with questions or needing information. Just a whole host of communications processes that we're working with. And then we tried really hard, spent a lot of time trying to create a very user-friendly and easy to navigate COVID-19 information page. And of interest, our website views went from 476 in February 2020 to 26,191 in April of 2020. And it's remained fairly high. It moves around some, but it's been fairly high since the beginning of the pandemic with people looking for information. It's been a challenge answering calls from the public and providers and all that, and keeping up to date and being able to provide the most current information, and keeping our staff knowledgeable so that, some of us may know it because we're on a briefing, but how do you get it to the person that's answering the phone? So that's been a challenge. And then the whole legal authorities piece. So we have authority as a health department for directed health measures of our own, for issuing those at the county and the health district level, but not at the municipality level. So at the Hastings, city of Hastings level, we did not have that in advance. So one of the things we did early on was working with the officials in all of those little communities that had their own law enforcement, and signed memorandums of understanding, giving us the authority for disease containment activities in those municipalities. And those that didn't have their own law enforcement, that would move to the county sheriff, and we already had that relationship at the county level as a 4-county interlocal agreement type of health department. So quarantine and isolation authorities had to work on understanding what that meant, and how did law enforcement and the county attorney's office work with us on those different pieces. And we worked closely then with the governor's office and DHHS for the state directed health measures, which really took precedence and still does through this declared emergency in our state. So working with our local law enforcement and determining our process for enforcing those has been another piece that we've had these things in place, but we haven't had to use them at this level. We have the occasional active TB case that needs to be isolated. And if you have non-compliance there, you can have quarantine, or you can have isolation orders, and you can have quarantine orders for people that are exposed and potentially have the potential to expose other folks if they get symptoms. So there were things that we had in place, but we have never had to use any of these things to the extent that we are now. And that's kind of the picture of the whole pandemic. We were ready, we had plans, we have things in place. We had experienced the H1N1 pandemic. Years before, we had prepped very hard and lots of community involvement for avian flu types of pandemics, right? From looking at what might happen here. So lots of planning and some little bits of practice, but the extensiveness, the length of time that this has been going on, that's what's been really different for us, all of us across the nation, and probably across the globe, really. So one of the things that I wanted to mention about the directed health measures was that the state had put very restrictive things in place, and then through the period of the months from May, I guess, on May last year on, as the things changed and the environment changed, the data changed, we were lifting those restrictions. And it's a really fine balance, right, to restrict liberties and the ability to carry on business and education and healthcare, all those things, and even our social and personal lives that affect our mental health. There's a real balance between that and reducing the spread, and to find that happy medium. Not happy for everybody, for sure. You can never find it perfectly happy for everybody, but to find that sweet spot to help protect folks, but also to be able to feel like there's some hope and that we're making progress has been just a real interesting, I think, process this year. And I think we've seen the struggles that people, individuals and groups have had with this as it's moved through the different phases of the pandemic. And right now we're in a directed health measure that's has very few restrictions at all. All gatherings have no restrictions now, indoor, outdoor. They're not required to submit plans to the health department. That was one of the last things that came out this month, came out of the directed health measures this month. So really what's still in there is the quarantine and isolation pieces. And I'm expecting that this will probably be allowed to expire at the end of the month. I don't know that for sure. And it could be extended a little bit longer, but I'm thinking we're kind of to that point where they're going to let those expire. And then that would mean that it would just come back to our regular public health practices, what we do in terms of responding to pandemics. Doesn't mean that quarantine and isolation go away. It's just it's not part of a directed health measure that has certain legal and criminal really implications with the legal authorities of that. So let's talk a little bit about where we are right now. We have 4,896 confirmed cases, and you can see that on the dashboard. Actually, just to highlight, we are really proud of this dashboard, and I hope that people have found it. We have a main dashboard, which is the page I have up here. We had a Hastings data dashboard when we had the Hastings mask policy in place to help people track how we were doing in Hastings. And we're still doing that, but of course, policy is not there anymore. And then we started a vaccine data dashboard as well. So that's what I'm pulling from right now. So we're moving up towards 5,000 confirmed cases. We've had 91 confirmed deaths. The deaths that are related to COVID are, we don't report out until we have a confirmation on the death certificate. And that requires both the person signing the death certificate, saying that one of the causes of death was COVID, and also having a positive lab report from that person. So sometimes if any of those things are delayed, it can take quite a long time to put the two together and get to us. So often those deaths reported out are quite delayed, but 91 to date, which gives us a case fatality rate of 1.9%. We've been tracking positivity, and actually, Dr. Phyllis, you had asked about sort of highlighting the 4 counties a little bit too, so I should do that. So our cases in Adams County are 3,158, in Clay County 773, Nuckolls 548, and Webster 417. So we track all those things there, and then we're looking at positivity rates over time, and this is looking at the number of positive tests that come back from the number that were collected, or the specimens that were collected in a particular week. So what % of those are positive? And if you're doing a lot of testing, it's a pretty accurate look at what's going on in the community. And as you have less and less testing, then you're only seeing those that are maybe symptomatic that are going to get tested. And so it's going to be more inflated number because you're not really sampling well the entire population. So some of the changes are related to testing. And I can tell you that right now our testing is very far down. It's really low. And we have widespread availability of testing through provider offices, but the Test Nebraska has come down. Mary Lanning's not doing it anymore. In the last couple of weeks, they didn't renew that contract. Broadstone's not doing it right now. Webster County still is, and Hastings Convenient Care still is. So we don't have as much opportunity for the free testing. But besides that, one of the reasons they were standing it down is because it wasn't worth the staffing. It was just so low, the people coming through, the numbers of people, so that they just weren't finding that was worth the expense to staff it, and finding that if we have just one place, maybe that's enough. So testing's been down in part because people aren't getting tested, and in part because of the availability of it. So we're seeing an uptick of positivity overall. We started tracking back last fall, splitting out our positivity. So this was right now we're at 8.5 essentially number of positive tests this past week that were collected. But if we look at the long-term, if we pull out long-term care, because there's regular testing required in long-term care, and it was frequent, and it was lots of people, and it was sometimes twice a week. So there's high numbers of that. And when we had long-term care at 0 for so long, with lots and lots of of test results, then it was pulling the whole community number down. So we separated them out and we're saying, here's what's in the community. If we take out long-term care, and we're at 14.8 right now as of last week. And long-term care, unfortunately, has gone up just in the last week and a half because of some outbreaks in a couple of long-term care places. So now they're having to do more testing, and they've found some positives, of course, because it was an outbreak. And so that's some of the things that you'll see there. We have an uptick in the positivity. Our risk dial, we started last summer to help the community kind of have an idea of what the risk was based on a number of different indicators. And we're continuing to do that and share that. Some organizations have used that for developing their own policies and plans, or implementing their policies and plans. Schools, for example, were looking at it, not following it exactly, but seeing what was happening in the community so that they could implement their plans for restrictions or none. Or somewhere in between. And so that's been ongoing. And then we look at the 14-day average of new cases, and that's come down to just hovering above 8 for right around 8 for quite some time now. Our goal really locally was to get below 8 or below and sustain there. And we've we're not as low as we had been back in June and July, but it's been not too bad, so for the most part. Nope. And then if we look at hospital capacity, which is somewhere here, there we go. And we can get to that from our dashboard too. We have been tracking what's happening in our 3 hospitals so that we can know that's kind of been the whole thing all along, right? With the directed health measures, what we're trying to protect the healthcare system. We want to have fewer people that need to be hospitalized and fewer deaths. So what's the capacity there? And that's one of the indicators that we've started tracking. So looking at how many ICU beds are available, and that bounces back and forth depending on what's going on in the community with other diseases as well. But what we really pay attention to is the number of inpatients, the number of inpatients that are positive with COVID or hospitalized due to COVID, not necessarily that you've tested positive if you're in there with a broken arm, but that you need hospitalization because of COVID. And right now we have 4. We've been down for about a week and a half with 0 cases in our hospitals, and it's just steadily gone up here for a little bit. So we have a few more in the district. And then we've been looking at the percent of inpatients that are positive, and that usually tracks along with this, but it tells us something about the hospital capacity. And you can see back in November, really peaking in November and December, our hospitals were they were struggling. They were getting to the point where they didn't want any more. People need to prevent this so that we don't have more coming in here. We're at our max, we're exhausted, and this is enough. So December, vaccine became available. Yay! This was so exciting. It was a breath of fresh air, I know, for the public, but for our staff, amazing to have that something positive we were able to provide to people that helps them be protected, and it's just kind of turned our mental state around a little bit here with our staff as well. And so we've been tracking this. Right now, as of Monday, we usually update this once a week for some of these data. But as of Monday, 33% of our total residents are vaccinated. And when you're hearing these numbers, pay attention to whether a district or a state or the nation is talking about eligible people that are vaccinated, percent of eligible people, or the percent of the total population. Really, we care about the total population because that's what's going to make a difference. But oftentimes folks are focusing on, well, how many of those that can get it are getting it? And that's what these numbers are. So 41% of those eligible residents, 16 plus, we'll have to drop that now as of this week. We can say 12 plus, but this is 16 plus. So 41% are fully vaccinated, meaning they've gotten, they finished both doses of a 2-dose series or finished 1 dose of the 1-dose series. And then 47% have had at least 1 dose. And you've heard the conversations nationwide about, well, should we just focus on getting everybody 1 dose, or should we focus harder on getting folks 2 doses so they're fully vaccinated? And then we're tracking how we're doing in each county, those that are fully vaccinated versus those that are have had just one dose. We're looking at this based on age group, and you can see that our older age groups are awesome, doing really well. We have 79% of those that are 85 plus are fully vaccinated, and 76% of each of the 65 and over, 65 to 84. And then it's dropping off, but part of that's because it's delayed. We were doing the older population first, and they've had a longer time to work on that. And now, hopefully the 16 plus and then the 12 plus will start working on those. Race, ethnicity, we've been tracking that as well. We are not as far along as we'd like to with our Hispanic Latino community in our district with full vaccination, although we have a booster shot clinic coming up specifically for Spanish speakers. So this is their second doses on Monday next week. So that'll be great because that'll bump this up a little bit for our fully vaccinated. And I don't know, just of interest, you might see how the women are doing better than the men in terms of vaccinating. And then this is just a kind of how many vaccinations have moved through our health department, and regardless of whether there are residents or not, because the people some that are residents can get it anywhere. They could get it other places too, but this is just looking at how much we've moved through. And so we had sent through our health department almost 22,000 vaccines since December. And that does not include anything that was going to long-term care through a federal pharmacy program. It doesn't include anything that's coming through the retail pharmacy programs that are at Walgreens and Walmart and Burt's, for example. So that's just the ones that had come through the health department to our providers and with our providers. So plugging along there, it's a little slower than I'd like. Our goal, like I said, is, or maybe I didn't say it, but our goal would be to get 70% or more fully vaccinated. So we're, halfway there. And I feel like one vaccine at a time. We'll just keep working on this. This week has been exciting to have the Pfizer approved for 12 plus. And we're getting ready to announce that we'll have clinics next week for that. We'll be getting some Pfizer early next week. And so we'll be ready to start that. We've been getting quite a bit of calls from people about that. They're interested, their kids are interested, or they're interested in getting their kids vaccinated. So we're excited about that opportunity as well. Let's see. Oh, I want to talk a little bit about variants too. So the variants have been of concern. There are variants called specifically variants of concern that have been identified. The CDC has a really nice website that summarizes those. And I'm sure that you've seen how some countries have been, the wild type coronavirus is really not the major one anymore. It's been overtaken. The foothold by the variants has occurred. And we've seen that in some of our states in the United States as well. We are tracking variants and analyzing for those. And so there are certain red flags that public health looks for, local public health looks for, and we request that those get sequenced. Sometimes it's an outbreak, sometimes it's travel, sometimes it's a younger person has a more severe illness, to get those sequenced at this state. And it's very expensive to be sequenced, but they're doing a pretty good job compared to many other states now. They were a little behind, but they're doing a pretty good job getting them sequenced. And we have primarily the B117 or the United Kingdom variant in Nebraska at this point, and probably the tip of the iceberg that what we're seeing. It's probably much higher prevalence than the numbers that we're actually seeing sequenced, but that's the primary one. And you probably heard that there was we have some P1 and we have some of so some of the Brazil and some of the South Africa too, but California variant is another one. And so we've got all these variants that are being identified. And one of the reasons they're concerning is because they can cause more severe illness, some of them, and some of them are much higher transmissibility. So the B117 is about 50% higher transmissibility than the regular coronavirus that started out here. And that means it's going to spread more easily between people. And if you're not protecting yourself, then it's easier for it to take a foothold and spread and cause severe illness among those that often younger folks are getting more severe illness with some of these variants. So that's why they're of concern, and we want to track them and let people know what's here, and also that they can't completely let their guard down. The vaccines have really good, they're safe for one thing, but they're also very effective at reducing severe illness and hospitalization and death. Not always protecting everyone from getting it or being infected by it, but from severe illness, which is really the point of having the vaccine. Any vaccine is to prevent the illness and disability and death. So that's a good thing, and that's a reason to encourage vaccination now, is because we have those variants. The sooner we get vaccinated, the less chance of those variants taking more hold, and the quicker we can get back to other more normal sorts of activities and settings. You probably heard too that the CDC yesterday said, oh, if fully vaccinated folks were free to be in indoor or outdoor gatherings without masks, that we have that protection. They are seeing the science supporting that, as I understand. So that's, I think, newly freeing for many people. And we've had people already saying, I came because I don't have to wear a mask anymore if I get vaccinated. I've heard that from the CDC. That's why I'm here to get vaccinated. So we may have some of that. We may also have some folks that feel like they're not getting vaccinated, but it's an opportunity for, I'm just not going to wear my mask anymore because this is what most people are not doing it anymore. So that's what I'm going to do. So some of those challenges of sharing information and providing information to help people make good decisions, and frustrations with where people are getting their information. And sometimes we can't really spend a lot of time saying, well, you're getting your information from someplace that's not reputable, and arguing about that. So we end up just continuing to stick to our messages of, here's the science base at this point, and that may change over time, because we're learning new things and we're paying attention to the new science. And so those recommendations may change, and here's the current recommendation. And so sharing that information to help people and organizations make the best decisions they can for their constituents, for their students, for their employees, for their communities. And that, I think, is one of the things that's been both most satisfying about this, is our ability to work with a lot of different stakeholders and to have the opportunities to do that, as well as been some of the most frustrating things maybe is how that communication can be an issue, and how we can best get around some of those barriers for good communication to all stakeholders. I think I'll stop there, actually. And Dr. Phyllis, is there anything else you had hoped I would talk about? And I'd be happy to try to do that. And if not, then I'm happy to take questions and try to answer anything you might have.
No, I think you covered basically what I'd asked you to cover.
Oh, yeah, Judy, a comment about people saying they are vaccinated even though they aren't. Yeah, I mean, I think my husband and I, in fact, talked about, I think we'll continue to wear a mask when we travel on planes, or, are going places where we don't know status of folks, that just, and then we won't get influenza and bronchitis and the other things we always get when we travel on planes. or go places with lots of people. Sorry, I droned you all into boredom.
No. I guess I had, more questions on the things that came out yesterday. I mean, there's no way to tell who's been vaccinated and who hasn't. And so when you go to the grocery store, you pretty much still want to wear a mask, because
and they talk about it in most situations, but there are situations where wearing a mask would be advised, and you want to consider, are you around folks that are at a higher risk and maybe are immune compromised, or more likely to be impacted by illness. And so considering who you're around specifically is helpful. But I think what it tells us is that you know, we have our circle of family or friends that are, and we know we're vaccinated, then let's enjoy getting back to some normal activities with those folks. I mean, that's exciting. That's one of the reasons we have the vaccine, and we need to get to that point.
Michele, thanks so much for coming in and talking with us. I really appreciate that. I know that the stress must have been incredible for you and the people that you work with. Do you feel comfortable talking about that?
Sure. It has been amazing trip this past 16 months for our staff. And we've seen it across the state with health departments, and actually across the nation. We felt fortunate that we hadn't lost any health directors through the course of this, which many states, either because they were forced out or because of various reasons, left their positions. But we go through phases where staff are at wit's ends and ready to throw in the towel, and sometimes it's because of the negativity and questioning of our roles and our professionalism, or our professional opinions, and our expertise. And it can go through stages like that when we have just a lot of negativity from the public and pushback on things, or refusals or hang-ups, you know, when we're trying to do our jobs. So sometimes it's that, and sometimes it's just long hours and not being able to take vacation or get away, because there's cases that come in all weekend, and you know, you need to follow up, and our goal is 24 hours after you get a report to finish that up. So some of it's that's been stressful, and we I don't know that we're doing that well with it. We have tried to implement some employee assistance types of things, and our board has encouraged us to try to understand how we can better allow and facilitate people to take some times off. And we try really hard. We have had to hire a whole lot of folks or contract, and so it's hard to find replacements for things that you're doing for all these different roles. And so people feel guilty then, like, oh, I can't leave because then all of this is going to be on somebody else. And so it has been difficult. And one of the things that has been really good, though, is we've had a lot of awesome feedback from organizations and stakeholders in our 4 counties, sending us food and gifts and just all sorts of stuff, nice notes. And we had a sticky wall up in our office where we were putting all those things up, and then like a frowny wall where we'd put the things that were stressful or whatever, but just to kind of put it up there. And so we've been trying different things, and I won't say it's been easy and that we're past it yet. It's been a really, really long haul.
Michele, are you planning on standing up any mobile vaccination units to go out into some of the more remote areas of the 4 county area to educate about vaccine hesitancy and or give vaccines?
So at this point, we are not. We had a different process than some health departments. I think some that's maybe working well in some areas, but we started out a heavy collaboration with local providers in the community. So we were transferring vaccine to those providers. They were first working on their own patients, the 65, well, actually older than that, but the 65 plus group. And then working into those priority groups that were their patients, but also many of them were bringing in community members as well and serving their communities. It was right there. It was, and it's their trusted health professionals for their communities. And that's worked very well. And we, as we've moved on to the younger ages, there hasn't been quite as much uptake there, but they've been working really hard in those local communities to do outreach and to do education and to find ways to reduce barriers that they can. And we just haven't felt like that's going to be the best use of resources for what's happening now. And we think now with Pfizer available and J&J available, so the one shot and done, that helped to sort of pick things up. And then the J&J pause caused some problems too, but we're kind of back to some real interest now with the Pfizer, I think, and it's just making it walk-in, so you don't have to register. You have to sign up for an appointment, just have walk-ins. That kind of thing will help people, I think, maybe more than having it right there. People travel a lot and come various places, so I think going out, there's so few people that it makes it hard to navigate. So we hadn't planned on doing that.
Do you have specific?
However, let me say we have done some strike teams. So I mean, we do go out to some businesses, especially like food processing plants or sometimes long-term care. We've been doing homebound, where we go out and get homebound people their own vaccine or their caregivers. So we have been doing some go out. It's not everybody has to come to us.
Michelle, I have a question about, I guess, understanding the statistics. For example, let's say someone has tested positive, but they die of heart attack. Can a dual diagnosis go on to a death certificate, or who determines without an autopsy what goes onto the death certificate, and if it goes in the statistics as a death due to COVID, a death due to coronary issues? How does that all happen?
Well, actually, Dr. Phyllis might be a better one to answer this, but I would just say that you can have multiple contributors to death, and that happens all the time, because you could have diabetes and heart disease or whatever. So you can have multiple contributors to death, and it's the healthcare provider, in the cases that I know about anyway, who are determining whether the cause of death has anything to do with COVID. So sometimes you might have been positive for COVID in the past, but it was a heart attack, and it doesn't seem to be any contributions, and so they might not say that it's a death due to COVID. It's just a heart attack. But if a provider thinks it has contributed to the death, then it would be added on there. And you have to have had it, and it could be that the test was a while back, but if they think that there was long-term effects of the COVID that contributed to the demise, then that would be included. And actually, Dr. Phyllis, I know you haven't worked through the COVID thing, but you might be able to say a little bit more about what happens on the provider side.
Well, we have to fill out the death certificates, and there are specific questions on the death certificates about whether somebody's been pregnant lately, or if they were smokers. But other things, they can meet what we call comorbidities. You have both at the same time, and the proximate cause is cardiac arrest, but the cardiac arrest was caused by complications of the COVID. So those both end up, and in fact, when you fill it out, it's the cause, and then there's spots 1, 2, and 3 where you add contributory or secondary causes of death. And I would assume that anything that has COVID, either as primary or secondary or comorbidity, would then cause that death to end up in the pile caused by COVID.
Michelle, I have a question about the long haulers, and I don't know if your department has anything to do with them, but it does seem that that's a major issue for a lot of people who have become infected with COVID.
We don't really have a process around doing anything with folks who are long haulers, but I know it's a huge issue, and I wish people knew a little bit more about the fact that many people have long lasting and maybe effects that will never go away. And there have been some great documentaries around long hauler COVID and those types of things. But we watch if folks are reinfected or there's vaccine breakthrough and those types of things. Sometimes people they may die much later. But it's really because they've never really recovered. And that whole recovery thing on our website has been uncomfortable for for me, really, because what does that really mean? And so we've tried to say, this means that you are this far past, you don't have to be isolated anymore. You're past your isolation period, and you're not hospitalized, so, I mean, you're not hospitalized or dead. So then you've recovered, because we don't know. I mean, there's a lot of folks that may have ongoing memory issues. There are other systemic issues, so brain, heart, lungs. So, it's really scary. I think that people, and young people even, could have long-term lasting effects from this. It's not the same as influenza in that regard.
One of the things that's so frightening, I think, of the people who have such devastating pneumonia with their COVID, that it destroys their lungs. And they may eventually survive and get off the ventilators, but they can't sustain life for any long period of time because their lungs are so completely damaged. And these are the people that are looking at lung transplants, but their lives are never going to be normal either. Luckily, that's pretty rare. But, I think the things we're going to have to be watching for are, if we start getting information that the variants are not sensitive to the vaccine, and then when they come out with recommendation of when and if we need to have booster shots. And we don't know those things now, and we just have to stay tuned. And if things change, it's not because people don't know what they're doing, it's because we've never experienced COVID before.
Yeah, well said.
Michelle, I have one comment I want to make. And what was the year that they of the tobacco settlement?
2001.
Okay.
Yeah.
What a lot of people may not realize is that we did not have statewide health departments. They did not exist in this state. There was the state health lab. There was a health department in Lincoln, and there was a health department in Omaha, and that was pretty much it, because the legislature and the governors never felt like it was necessary. And it wasn't until the tobacco settlement that went to pay for it, so they didn't have to use tax dollars, that we developed having these health departments. And if that hadn't happened, we would have been totally up the creek without a paddle. So something very terrible, having all the people who've been injured by tobacco smoking, the money that came from the tobacco companies helped us be in a much better position to face this pandemic than if that hadn't happened. Who knows if we'd have had health departments.
Right. And so we're celebrating that 20th birthday on Sunday. It was actually May 16th, 20 years ago when that was passed. And our health department was the first health department in the state formed under that bill. And we formed in November 2001, and we're the first one. So, and thanks to Judy Reimer, because she was instrumental, and others were instrumental in making that happen locally. So yeah, and that's been kind of interesting that we grew up together, these new local health departments, and so we are to the point now where we really rely on each other, and we're a really tight group of 18, 19 health departments. It's kind of adjusted a little over the years, and that's been critical to our response, our abilities to work with each other and come up with common guidance and bounce things off of each other. We are local public health, and we work with the state. We have to work with the state, but we are locally governed, and local boards of health and local control. And so local control, not when we have state directed health measures, but local control in general. And this is because we have these relationships locally, and we've grown up with developing these in the last 20 years. That's made this so much easier, I think, because we have had a lot of things in place in terms of relationships, and that's grown even stronger in the last year and a half, and is one of the things that's a success, I think, is that those relationships with the various entities and stakeholders across our district.
You do
Have
a
you,
marvelous job. Oh, I'm sorry, May.
it's okay, I just want to know if you've realized any more funding, any more permanent type funding when they've realized how important you are to local health.
In fact, we have. There was a bill passed, well, we were included in this year's budget for
Yes.
some more funding. So, and there'll be some additional next year as well. And then we'll have the first time in 20 years really having additional infrastructure funding for foundational public health capabilities. And it's really appreciated because some states are trying to take away state funding from health departments because they're getting all of this federal COVID funds, and we're like, don't take it. We don't have any to begin with, so don't try to take anything away. But that's been a real exciting thing just this last couple of months when they passed the budget to have us included in there. And there's been quite a bit of funding, federal funding coming through, and state funding to help with the COVID response. But this is not going to end. We're going to have COVID. I mean, we might have to have our own little COVID unit, to deal with this going forward. So we're seeing that there'll be a cliff probably in some of that funding, but from the feds. But if you think about 9/11 in 2001, we had funding that came in to help with bioterrorism things and to respond to anything that was, wow, we didn't know that this was something that public health even needed to be involved in. And so that funding has really continued in a low level all along. So 20 years later, we're still getting some bioterrorism funding to help us be prepared for those types of things, all public health preparedness in general. And I think I could kind of see this happening, that we would have a low level of funding for pandemic that continues on through federal pass through to the states that we get locally.
I just want to say just real quickly, I remember I was a rather new employee at the Mary Lanning Healthcare Foundation when our office brokered the formation of the health department. And I remember at the time when we were setting that up, wondering if there would ever be like floods or what would how this would progress. And of course, we've seen how our health department has taken on issues of obesity, drug, all sorts of public health issues. And while we're glad to have that, I think your statement, Michele, about how many hits you had, that just shows how now people go, oh, yes, we do need that. So it's really good to see. I'm glad it was there, and we're lucky to have you and all of your team.
Thank you. And we just really want to, our staff are so ready to pull back in some of the things that are really other public health issues that are of concern, our access to healthcare, mental health, substance misuse, cancer, obesity, and related health conditions are all things that our community can prioritize. And some of those things, are going to be exacerbated because of the pandemic. We'll have to work doubly hard to address those as going forward. But we're proud of the communities that we're in, and we thank all of you for participating in the many ways you have with the health department as we've grown and as we've addressed issues like what we're doing today.
Thank you very much for your time, Michele. I think our time is up, and I hope that the press who were listening in get a chance to ask you additional questions if that needs to happen.
Thank you so much, Michele.
No worries. Thank you. Happy to be here.
Presidents,
Yes.
we need a decision. I did ask the YW if we could meet in person, and we were going to wait to see what Michele said. So I should let them know today if we're going to have a total Zoom a virtual meeting, or we're going to meet in person or hybrid meeting.
Oh, wow.
We were leaning toward in person, except for people who weren't vaccinated and wanted to Zoom was my, and especially since what CDC said yesterday. But are there major objections to that? Or minor objections?
Yeah, right. Chris, is it possible to do the Zoom along with doing it in person?
Yeah, I did talk with, Laura, and we can work out something. It's not as ideal of a situation as what I was hoping for, but I think we can make something work.
Okay. Well, that sounds like the way to go then.
Okay, with a hybrid meeting, and so I'll confirm that reservation with Laura then. Okay,
Yeah.
Thank you
Good.
for checking.
Thank
with-
you so much, Belva, for bringing that up.
Right, right.
Okay, everybody take care.
Oh, but no salad lunch, right?
Oh, yeah,
Yeah.
whatever.
Okay.
Thank you all.
Right.
Thanks.
Thanks for having us.
Thank
You're
you
very
for
welcome.
being with us. Thank you.